Hello, my name's Fiona. I'm the Chief Exec of Southampton Hospital. I'm here representing Mary, Chief Exec at Hampshire Hospitals, and Ursula, Chief Exec at Portsmouth. I wanted to first of all read to you part of a letter that I and 4 other Chief Execs, including Simon Stevens, received last year from the mother of one of our patients, who we've called Sarah. Dear Chief Execs, my daughter has spinal muscular atrophy and has been confined to a wheelchair since the age of 19 months. Her interactions with the NHS in the last 6 months include outpatient appointments with 6 different paediatric subspecialists, inpatient stays at 2 different hospitals, GP contacts, sleep studies, and wheelchair maintenance visits. Recently, Sarah was seen 3 times in 1 month at Southampton. Each consultation lasted 15 minutes and involved us leaving school 2 hours before the appointment time to allow time for traffic delays and a 68-mile round trip. The travelling time is shorter to my local hospital, but sometimes we have up to 3 different appointments in 1 week. No attempt is ever made to arrange these interactions to make them as straightforward as possible for me or Sarah. I struggle to coordinate her care to minimise the disturbance to her education and to family life. Sadly, no one seems to be responsible for actually delivering an NHS which works across organisational boundaries in the interests of patients. After receiving this letter, I met with Sarah and her family to understand the reality of their experience, and I promised them that I would try and make it better.
Thank you, Fiona. I'm a general paediatrician. I'm based in Winchester, and my colleagues and I bring you this bid on the back of years of collaboration, from personal working relationships to formal networks. However, what we're proposing today represents a major frame shift of approach. At our junior doctor induction last week, I told them that I think our families expect 3 things from us. They expect an accurate, timely assessment of their child. They expect a coordinated and clearly communicated child-centered plan that's delivered by teams that are trained to do so. And they expect to be partners with us at every stage in their child's care. We have a collective ambition to raise our game to deliver on these expectations. We are tired of working in competing and disjointed systems, apparently designed to make it harder for us to deliver our services. Services designed around institutions and historical structures, not around the families and the communities that we serve. We're tired of seemingly endless battles, fighting through red tape that we wrap our institutional silos in. Parents such as Sarah's should know and should trust that as she moves through the system, the pathways work. They need to be able to trust that we communicate, and they need to know where to go for appropriate, timely help as their story unfolds. The integration of the elements of Sarah's care is unfortunately patchy and often ad hoc. The issues have been well rehearsed over the last 2 days: sustainable staffing, recruitment and training, sharing of information, timely access to appropriate levels of care and expertise, and systems that are designed to speed up rather than slow down accurate, informed decision making. So we're asking how to find a new way of working. And unfortunately, we're realizing that the answer is, if I were you, I wouldn't start from here. So we believe we've got an opportunity today to start from a different place and to turn the question around. Rather than asking, what can we do with what we've got already, we're asking, what can we do with a blank piece of paper and a shared philosophy?
My name is Peter Wilson. I'm a Pediatric Intensivist from Southampton Children's Hospital. So the first question we have to ask ourselves is, why us? Why should we be part of this? There are strong clinical relationships and mutual respect across the 3 trusts. My colleagues in Portsmouth and HHFT and ourselves have been working for 10 years on developing clinical networks of care, and we feel that we've done a very good job. But we keep on coming up against boundaries that we cannot overcome. Recently, our chief executives have started to do the same, working in collaboration rather than in competition. We have very good experience in looking at this kind of system design. Over the last 2 years, we've worked with the John Radcliffe in Oxford to create at tertiary level joint services networks around some of our tertiary pediatrics. We understand the challenges lying ahead, and we truly believe that we have the clinical and political will to make this work. We have strong patient engagement. Our patient experience panel has been involved in discussions over a number of years around patient pathways, and they are integral to this bid. So why do we need a vanguard? Vanguard offers us an opportunity to work with an exciting group of specialists to look beyond constraints of trust, finance, and governance. We already have good relationships and trust. What we are lacking is the structure to make this happen. We will need support and real organizational change, despite our saying that we work well together and we trust each other. Whenever clinical or trust sovereignty is threatened, challenges will happen. We will need support in how we access information differently. To allow Sarah to move seamlessly through the system, we will need an IT solution that is responsive to her needs, not to the organizational needs. The Southern Vanguard is already working on this, and we would like to build on their success. We will need support in ensuring commissioning and governance is not a barrier to Sarah's journey. This would mean working with commissioners to create financial structures that follow the patient path, not the organizational path. We would also need to work with the CQC and our regulators to allow the governance structure that truly allows the full patient pathway to happen. So how would our becoming part of this community allow change for Sarah to be in the better? A more responsive, integrated care model would ensure that Sarah would receive treatment closer to home. She would have fewer trips to hospital, unnecessary trips to hospital, through a single point of access system. We would also ensure that if Sarah became acutely unwell, it would not mean her moving backwards and forwards repeatedly between trusts just because finances and governance say that they have to do so. By concentrating on the patient pathway rather than organizational boundaries, we would decrease variation of care across the system, as well as developing a more sustainable workforce model. Our aim is to create a truly flexible model that can work across an entire region. This would ensure we would not only improve care, but also become more efficient. We believe that our being part of the vanguard will allow us to create a system that would not just provide seamless care for Sarah and other children within our 3 trusts, but for children across the UK. We believe that it has the same potential for our adult colleagues.
Thank you very much. Can I have questions from the team from Wessex, please? Down here, table number 14.
Sorry, Trevor Fernandez, patient, East of England. This might sound a bit naive, but I've noticed on a couple of the applications there are some similarities, certainly with this and the application excellence through paediatric partnerships. Is it possible to combine the best of both proposals and have one vanguard supported? The only difference I can see is the geographical.
Do you want to go first? And then, Sam, can somebody get a microphone to Samantha, please?
Absolutely, from our point of view, it shouldn't be a surprise that to us the 2 things are similar. Both of them come from the Children's Hospital Alliance, and I know that Louise Shepherd, Chief Exec at Alderhay and Chair of the Children's Hospital Alliance, agreed with Simon Stevens that this group, of which we're obviously both part, would work nationally to see how we could think through some new national models for children's services. And so we absolutely support the Alderhay proposal, and I know that that's mutual. So I think the nature of paediatric services is we don't kind of like competing that much anyway.
I think there's a reflection from today, and we would really welcome comments from people when you write down your votes about how best we can take forward a number of the elements that we've heard from a variety of Vanguard applicants today, whether it's around children's, whether it's around cancer or mental health. So we would really welcome views on this. It's up for discussion.
Question on table number 10.
Thank you. So I sit on the Alliance as well, and I hope you're aware that within NHS England we have an acute care programme for children and young people, and we're working towards just this very thing of looking at the proper horizontal and vertical integration of children's services. So I think we're going to work together over this. But a specific question, you used Sarah, who of course is an excellent example of the sort of child that we all see within our hospitals, somebody who is a multiplicity of service users. So my specific question is, have you looked actively towards the integration of mental health in your physical health pathways?
Yes, absolutely.
So one of the things that I've noticed, I'm part of a trust that was a merger of two hospitals. One of the things that we noticed was when we merged, actually there were bits of our CAM support, particularly for the acute mental health working, that we were good at, that our partner trust weren't so good at, and actually the collaborative working has meant that 3 years down the track we've got a much better system for assessing and looking after acute mental health problems within our hospital and across the patch. And I think that's what's so exciting for me as a general paediatrician. I'm seeing children and adolescents in this sort of situation on a very regular basis, as you say, and they're a particular group of young people who are really struggling, and actually getting the right people in and assessing them and learning from each other is something that's very, very exciting to me, certainly.
Can I just quickly add? Could I just add to that? Sorry, Jackie. I think one of the things just to add is that we've got very good in paediatrics, as you know, at a tertiary level at getting this integration right. I think what we've not been good at is at a secondary and primary level. And that's really one of the reasons why we feel passionately about this Vanguard, is that we believe that this is part of the whole patient journey, not just the tertiary secondary interface. It's got to go through the whole bit.
We have two questions on table number 27. Could you be quick, please?
We'll double tag them. So, Claire Panica from Basildon. I'm really interested. You talked about a truly flexible model across the three organisations. Can you just describe what the opportunity and also the challenge of the workforce is in that? And I'm just going to pass to my colleague while you think about that one.
So, do you want to ask another question, or can I?
My question, I'm Karen Partington, Chief Exec of Lancs Teaching. So you spoke with great passion about your services. And I just wondered, you've clearly articulated a very compelling vision. If you fast forward to results day and you open the envelope and you haven't got the Vanguard bid, what are your next steps?
I think that both of them are excellent questions. Can I answer the second one first? The answer is that one of the great things about having put the Vanguard bid, I've been talking for 5 years about this, and there are people in this room who work in Wessex who are very bored of hearing me talk about this. So the answer is, we will keep going. One of the great things about the Vanguard is we've now got the three trust executives' support. The biggest issue for us really is around how we commission and how we get the governance right. Governance is a massive problem especially around paediatric services, and commissioning within the children's hospitals, and this is nationally, about 90% of our 80-90% of our funding comes from specialist commissioning. For our district general hospital colleagues, 90% of their funding comes from CCGs. We have, just amongst the three trusts, we have 6 CCGs and a local area team to deal with. They are all on board. We spend time talking to them. We meet with them every 2 months. They're all on board, but they have the same problems as we do, which is, what currency do we use to break these down? So the answer is, of course we will continue to do this. We've been doing this for 10 years. We will keep on doing this. It will be much, much slower and much harder, because the real issues of breaking down the currency barrier and breaking down the governance barriers are hard. The other question is around workforce. I think from each trust we have real strengths that we need to learn from each other. The problem is the pathway. So within the children's hospital we have real strengths at a tertiary level that we can move out. We already do 500 clinics a year within our district general hospitals, 200 operations a year in our district general hospitals. We have secondary paediatricians who work at the moment in GP practices. So we're already doing that. We have problems around community paediatric support and that end of the pathway. Within district general hospitals, they have some other problems. So I think that it'll be about how we look at the workforce as a whole and make it a single unified workforce that we can move forward together with.
Thank you very much for the questions. So can I have a big round of applause from the team from Wessex, please?